Yeah. Okay, friends, after having finished the overview of GUTB, we will move on to the next subtopic, that is etiopathogenesis of GUTB. It's very important for us to know the brief historical outline of a patient with GUTB, because tomorrow, as a general practitioner or as a practicing physician or as a practicing surgeon, you need to identify a patient walking in with GUTB to your chamber. So if the patient gives a history of GUTB, you need to identify that all these history are pointing towards the GUTB. So for that, I will start off with a brief history. Here we have a patient who is a 35-year-old male who predominantly complains of loss of appetite, loss of weight, and evening rise of temperature. This is a deadly combo which points most often towards a GUTB. And this patient also gives a history of pulmonary tuberculosis, which was treated 15 years back with antituberculous therapy for 6 months. So this is the history that the patient is giving to you: loss of appetite, loss of weight, and evening rise of temperature. These three symptoms are hallmarks of tuberculosis. A patient having any of these three symptoms is considered to be having tuberculosis unless proved otherwise. Well, I'll tell you why exactly this happens a little later, but for the time being, at least you should know that this triad of symptoms point towards the tuberculosis. Yes. And this patient also complains of frequency both during day and night time. If you can see here that the patient voids about 15 to 20 times during daytime and 10 to 15 times he is getting up at night to void. And this has been going on for the past 3 months. And apart from frequency, he also has got urgency and dysuria, urge incontinence, suprapubic pain, and sense of incomplete evacuation. So all these point predominantly towards the storage symptoms, and this patient does not have any difficulty in voiding. That means he is not having any straining to void. There is no thin stream, no poor force, no prolonged duration to void, but only thing is that he is having a sense of incomplete evacuation, which is not because of holding up of urine, but because of this frequency that sets in patients with the GUTB. And on examination, clinically, everything is normal. So with this sort of a history, what are the possibilities that you will think of? The first and foremost is because he has had the triad of symptoms, loss of appetite, loss of weight, and evening rise of temperature, you will definitely think of the possibility of GUTB here. The first differential diagnosis in these individuals will be genitourinary tuberculosis, not because of the constitutional triad of symptoms that the patient presented with, but also because of the intense storage symptoms that he has come to you with. So this patient has got a triad of constitutional symptoms: loss of appetite, loss of weight, and evening rise of temperature, and also storage symptoms related to bladder involvement. So the first and foremost diagnosis that you will think of will be genitourinary tuberculosis. The next common diagnosis that you will think of will be an uncomplicated UTI. A large vesicle calculus with chronic smoldering infection can also present with those constitutional symptoms and the bladder symptoms subsequently, or any overactive bladder with storage LUTS. LUTS means lower urinary tract symptoms, or sometimes a PBS, painful bladder syndrome, can also present in this form. So now I was repeatedly emphasizing on this triad of symptoms, that loss of appetite and loss of weight and evening rise of temperature. So now you need to know why this triad of symptoms are hallmark of tuberculosis, or in other words, why should a patient develop loss of appetite, or why should a patient develop loss of weight if he gets affected by tuberculosis. It's very important for you to remember that leptin and body fat play a great role in deciding on why those patients with tuberculosis develop loss of appetite and loss of weight. So what is leptin? Leptin is an anti-obesity hormone that is predominantly expressed in adipose tissues. So this anti-obesity hormone, so what does it do? So what does a leptin do otherwise? It increases the metabolic rate, it increases the basal metabolic rate. The BMR of the body is increased, as a result of which the energy expenditure is also increased. When the BMR increases, what happens? The energy expended is also increasing. So that means these patients will have a higher burning out of the calories that the patient have got. And in addition to that, the leptins will also cause a decrease in food intake. So a rise in BMR, a rise in energy expended with a decrease in food intake. So less food intake and higher energy expenditure. What does it do? That means if these patients have a higher leptin levels, there is a decreased food intake and increased energy expenditure. Or in other words, a patient with lower leptin levels will have an increased food intake and decreased energy expenditure, resulting in obesity. So these patients with the increase in leptin levels, they will be having a loss of weight because the food intake is low and the energy expended is also very high here. So that is the reason why increase in leptin levels will cause loss of appetite and loss of weight. But what has that got to do with the tuberculosis? What is the correlation between tuberculosis and leptin? What happens here is that in tuberculosis there are two events that happen. One, there is an acute event, the other one is a chronic event. So what is the acute event that happens in tuberculosis? It's an acute pro-inflammatory cytokine IL-1, IL-8 release. The release of IL-1 and IL-8 will also result in a rise in the leptin levels in the adipose tissue. So what happens if the rise in leptin level happens? It causes loss of appetite and loss of weight. So tuberculosis, through its acute manifestations, will cause a rise in leptin levels, resulting in loss of appetite and loss of weight. Whereas tuberculosis will also cause a chronic smoldering inflammation in the body, which will cause a release of tumor necrosis factor alpha. The TNF alpha will be released in excess in these individuals with chronic tuberculosis. As a result of it, this can also cause anorexia and loss of weight. So either way, if you see these patients either with an acute tuberculosis or with a chronic tuberculosis, chronic form of tuberculosis, they have a loss of appetite and a loss of weight, which are characteristic hallmark features of tuberculosis. The next one is why is there an evening rise of temperature? A patient who complains of an evening rise of temperature is considered to have tuberculosis unless proved otherwise.